Excellent. Thank you very much, Carol, and thank you everyone who has joined us this afternoon. Um, my name is Ethan Moore. I'm with the Centers for Medicare and Medicaid Services, specifically with the Electronic Health Records Incentive Programs. I do a good number of these types of presentations, although I would like to point out that I am not one of the policy writers, and so while I will be able to, I hope to be able to answer a lot of questions. I look forward to some dynamic feedback from you all. If there are questions that I can't answer or that we can't get to today, I certainly will look forward to the opportunity to take those and hopefully get back to you. So with that, I'd like to just mention that this presentation is designed to provide you with an overview of the EHR incentive programs, Medicare and Medicaid. They are separate. And to give you a peek at what the registration and attestation systems look like. So you'll see some screenshots. We'll talk about what the program is as a whole, what it's intended to do, and how it all works. So the most important part of the Electronic Health Records Incentive Program is meaningful use. And meaningful use is exactly what it sounds like. It's how do you meaningfully use electronic health records. The meaningful use guidelines are a series of data points that have to be captured and reported on by the EHR. Those data points are designed to improve quality. They're designed to help physicians interact with their patients and families, and to help patients and families be more fully engaged in their own health care. It's a step towards overall coordination and interoperability of data. That's really the first step in meaningful use. And as you saw in some of the products that High Tech Answers is going to be rolling out in the future, there is stage 2 of meaningful use, and we anticipate a stage 3 as well. Those rules have not been written. There are policy discussions happening right now to figure out what stage 2 is going to look like. What we know for sure is that meaningful use is a process. It is something that we are achieving little bit at a time, and right now we are in stage 1. It's important to note that meaningful use in the Electronic Health Records Incentive Program was authorized under the stimulus bill, the ARRA. These funds are dedicated funds. There is no concern, there's been no legislative initiative to remove or rescind the authorizing law for these programs or for these funds. It's also important to note that every state so far is in the process of implementing their own Medicaid EHR incentive program, and right now about 16 states have successfully gone online. So what we're looking at and what the Recovery Act specifies for meaningful use is certifying certain EHR systems and then dictating what those systems have to be capable of, which in turn dictates how we have to use them and what they're going to do, what they're going to change in terms of the interaction with patients and the workflow in the physician's office. And ultimately, what we're looking at is an arc. This is a progressive program. We're starting at the beginning here, and all we're trying to do right now is to get everybody on the same page with certified technology. Certified technology is designed to be secure. It's designed to capture all of the data that's necessary and required in law for meaningful use. And it's most importantly designed to be interoperable so that the data that you collect can be shared with other systems regardless of the vendor. And ultimately, as we move into stage 2, as we move into stage 3, we're looking to have that data inform our clinical practices and help improve outcomes. I usually like to look at the meaningful use arc as kind of like building blocks. We're starting off in stage 1 with certain requirements and thresholds, and it's very important to know what those thresholds are. We'll get into some of the resources to help you with that later on. But the thresholds are likely to change, and that's what we're going to see in stage 2 and 3 is what some of the options are now may become mandatory, what some of the thresholds are now may increase, those thresholds may change. And so, again, we don't know what's happening yet with stage 2, but those are the kind of things we can look for as we see the rules coming out later in this year or the beginning of next. So, how do we achieve meaningful use? Meaningful use in stage 1 is reported through a 90-day period of time. After that, it's a full year. That's as the rule is currently written. It's important to note that year 1 of meaningful use is the first year that the provider actually reports. And so if a provider reports in calendar year 2011, that's their year 1. If they report in calendar year 2012, that's their year 1. And year 2 would be subsequent to that. So for the first year of meaningful use reporting, and reporting and attestation are kind of the same thing. For the first year of reporting, it's a 90-day window of time, and the 90 days is for the meaningful use of your certified EHR. The certified EHR has to be a complete system. You can purchase complete systems that are kind of nuts to bolts, all-inclusive. You can purchase complete systems that are modular, and all the different modules are individually certified, but they work together to present a complete system. You can use multiple systems simultaneously, as long as those systems, as you're using them, are themselves certified. And you can check certification through the Office of the National Coordinator website and through the Chapel website, and that the links for that are later on in the presentation. So, with the 90 days of reporting, it's a rolling 90 days, and so I'll point out in some of the screenshots, but it's designed to be flexible. If you report in the first 90 days, so you start in June or you start in July, or maybe you've already started collecting data in your EHR and you go through 90 days of use, your EHR will create a report for you, and you plug all that information into the attestation system. If for some reason the attestation does not work, if it's not effective and you fail on some measures, you can select another 90-day period. It can be overlapping. So 89 of those 90 days can be exactly the same as the previous 90-day window that you had reported on. Of course, I would caution you that if you have dramatically different numbers that you're reporting between one 90-day period and another, and a majority of those days actually overlap, that might trigger an audit down the line. We don't have guidelines or guidance on the audit process, but that is forthcoming. We are expecting that later this summer, although we can't say exactly when those rules or that guidance will be issued. But an audit process is going to be part of this program. But the 90-day window does allow you that flexibility so that you can choose a different 90 days to create your report. Now, the attestation process is what actually allows you to do the reporting. And in the attestation process, you'll be essentially walking through it. It's pretty straightforward. Your EHR software will actually provide you with all of the information, and you just take it from the report and plug it into the online system. Okay, so not every objective for meaningful use actually applies to every practice. And so what you need to be aware of is that for each measure, there are unique thresholds for that measure. There's guidance to kind of walk you through what that measure is, how you attain it, and how you meet the minimum thresholds. If you're an eligible professional, you have different thresholds than if you're an eligible hospital or a critical access hospital. And for example, as you see here, if you're a dentist, you don't perform immunizations, chiropractors don't e-prescribe, and so you would not have to meet those particular measures. Now, if you're not able to meet the minimum number of measures, you do have to you can put a 0. You wouldn't put a 0 in the numerator. You wouldn't put a 0 in the denominator and a number, some other number in the numerator. Obviously, your EHR system wouldn't report that out, but you can put zeros in the numerator and denominator, and that will register as data being put into the system. I'd also like to point out that some of the resources that CMS has made available will really help walk through the system and get you comfortable with the actual process of attestation and reporting. There's actually a calculator online that serves almost like a TurboTax kind of function, where you can go in, you can take the numbers that are reported out from your EHR, plug them in to the calculator, and it walks you through just like it will through the official, formal online system. And it'll walk you through the measures, it'll walk you through the requirements, and actually tell you when you're meeting them and when you're not, and if you would be successfully attesting. Now, it's not a dynamic system. Your EHR and the online attestation system, they are not dynamic in the sense that if you put information into the calculator, you can't automatically load it into the online attestation system. Similar with your EHR, if you create a report from your EHR, you cannot automatically load that information into the online attestation system. That kind of functionality may be available in the future. From a systems perspective, we are looking into it, but at this point, it's not available. You're going to have to kind of more manually, I suppose, take the data and input it into the online system. Okay. So here are the lists of meaningful use core objectives. And there's a reason that there's a difference between the core objectives and the clinical quality measures. There are different specifications and requirements surrounding those two. And there also are some significant differences as well as similarities between the objectives for the eligible professionals and hospitals. So what we see here, if we go down, is evidence of the intent of meaningful use. We're looking at electronic exchange. You see that. You see health information sent to patients, decision support. We're talking about syndromic surveillance data. These are things that are designed to achieve the objectives of meaningful use when we talk about engaging with families and with patients, when we talk about supporting public health. In this list, at least one of the public health objectives has to be selected, so your system and indeed what you record must include some of this data. And so you see there are minimums. You can select some and not others. And that will also be, that degree of flexibility is determined largely by the type of practice setting you have. You may not, as a chiropractor, you may not be able to do a drug formulary check, as it says here in the menu set on the right. So maybe you generate a patient list instead. So there's some flexibility there designed to take into account the variability of practice settings. It's the same thing with hospitals. So we'll kind of move forward with that. And at the bottom of these, and I believe this presentation will be made available to you, you see the actual websites where you can go to get more information. Okay, so we see that there are a number of requirements, and with the clinical quality measures, there's even more opportunity to make a selection out of the total. Here's an example of what you can expect to see with, and it's probably a little small for you. It's just meant to be a kind of a visual representation of what you can see with the more in-depth description of the meaningful use requirements and specifications. It gives you more information about, what is the definition of some of these terms we're using? What are the actual requirements in terms of the numerators and denominators? What are the exclusions? So it'll walk you through on a very detailed level whether or not a particular measure has to apply to you, or whether or not you would be excluded from meeting that measure. So this is what the actual system is going to look like when you log in. You will log into the registration and attestation system. You'll select whether or not you're an eligible hospital or eligible professional, and that kind of kicks it off. Now, your actual registration process can be done at any time. You can complete your registration now, and there's absolutely no obligation in doing so. You can complete your registration 30 seconds before you start to attest. There's no restriction there at all. Your registration determines your user ID login information for the attestation system. So they are linked in that sense. But the registration process does require collecting some information beforehand. You're going to be you're going to need to put in your PACOS information. I think we'll see here. Yeah. So you'll see the NPPES. So you're going to need your NPI. You're going to need your particular provider information in order to register. Once you register, you will have what you see here, your user ID and your password. You put that in, and after you have registered, so then you'll attest. this is the initial attestation screen. The fields at the bottom will be populated once you start the actual attestation process. So obviously your TIN, your tax identifier number, your NPI will be unique. The status and program year, that'll change as you go through the system and as you go through the process. So you'll see there whether it's pending. You'll see whether your application is, if it's successfully submitted, if it's failed or needs to be resubmitted, if you're in process. You'll see that kind of as an overview. Let's see. Okay, so as you report in the attestation process, you're going to actually be reporting on the numerators and the denominators. The denominators are all of the patients you've seen or admitted during that period of time. So that reporting period is for year one, it's that 90-day window. And that is regardless of whether or not their records were kept using the certified EHR. And the denominator is also going to be including all of the patients, regardless of the measure itself. The numerator is going to be specific to the measure and to the number of patients that where that measure is actually applied. And here we see an example of what that field will look like in the attestation system. So for this, we're looking at the core measure of the computerized provider order entry, or CPOE. And one of the reasons this makes for a good example is because you can see that you have a bunch of different options here. You can signify whether this measure, whether you're excluded from reporting on this measure. And you also see, so that's just a yes-no checkbox. You can also see that you put in your numerator and denominator. If you don't put in those fields, you won't be able to continue. But essentially, you are manually, literally just typing in, in this case, 120, and then clicking over 125. And quite frankly, like I said, there's no dynamic check with your EHR system. And so we are largely taking your word for it. This is not something where, we're anticipating a lot of problems, but of course that is why we are implementing an audit process down the line, just in case there are significant problems. And we're not looking to really go after anybody for small errors. Changes can be made before you submit and send over, essentially legally signing and sending your report in. You can go back and make changes. And that's where you see this Save and Continue button. So once you click on Save and Continue, that will take you to the next screen. Well, no, it would not look like that. It will take you to the next screen, but it will also save everything that you've entered so far. So if the power goes out or you get sidetracked, you have to do something else, as long as you hit Save and Continue, you can go back in at any time, pick up right where you left off. So all of your clinical quality measures, the corns, the alternate set, you choose which ones you want to report on, they have to be met. Now, there is a little bit of a difference with the clinical quality measures and the core, and those have to do with whether or not you're recording and reporting them through your certified system. You absolutely, with the clinical quality measures, your system has to be able to record all of them, whether or not you only report on 3, as you see here for eligible professionals of the 38. And here's an example of what the clinical quality measure screen will look like in the attestation system. We see again you have your numerators and denominators, and you will be manually putting those in. Save and continue will move you forward. Now, this is also something that you would see in your in the calculator function online. You see a summary, and this summary will tell you a little bit about the measure that you chose, that you put information into, and it'll tell you what the status is, whether it's accepted or rejected, and it'll give you the reason for why that determination was made. If it was rejected, it might help you identify why it was rejected. Maybe the threshold wasn't met, and the numerator and denominator you didn't meet that minimum requirement. So that's the system for Medicare. For Medicaid, it's a little bit different. For Medicaid, it's dependent by state. There are slightly different eligibility requirements as well. And for eligibility requirements, I would recommend, again, through the CMS EHR Incentive Program website, there's a tool that will kind of walk you through to see, I'm a chiropractor, or I'm a osteopath, and I'm eligible for the Medicaid program, may not be eligible for the Medicare program. Medicaid allows you a little bit of flexibility. It's based on the state actually implementing a system. And as I mentioned, there are about 16 states currently who started their Medicaid EHR programs. To date, over $83 million have been distributed through the Medicaid program to eligible professionals and hospitals. We have over 42,000 eligible professionals and hospitals registered for the system, and that's Medicare and Medicaid eligible. And for Medicaid, what we see is a slightly lower bar or threshold for the technology requirements. This adopt, implement, and upgrade. That's only in Medicaid, and it's only for the first year. And again, you can read this. It's very much what it sounds. Adopt, you need to purchase it. You need to get it. You need to install it. Implement, you have to start using it. Upgrade, a lot of folks already have systems. EMR systems may be part of a complete electronic health record, and so maybe you only need to you need to upgrade that system to get it certified. And so we take stuff like that into account and make it a little bit more manageable to actually get the technology, the certified technology that you need to start meaningfully using that technology. So the biggest difference between the Medicare and Medicaid programs is that, quite frankly, you can get more money with Medicaid than you can with Medicare. For eligible professionals, you can get up to $63,750. For Medicare, EPs can get up to $44,000. Now, this is total. This is cumulative over 5 years. In the first year, for Medicare, eligible professionals can get $18,000. Now, that's it's got a kind of some unusual language around that. It's 75% of of billable Medicare claims. So essentially, that means that you have to have $24,000 of Medicare claims that can be applied through the system that we can see, we CMS can see, and once you reach that point, and that's for the previous calendar year, once you reach that point, you will be able to, assuming you have successfully attested and registered and all of that, you will be able to receive that first year payment of $18,000. And again, that's for first year. Second year is a little bit less, but in total, over 5 years, your maximum is $44,000. Also, the important thing to note with both of these programs is the timeline. The last year that an eligible professional can register and attest for the EHR programs and receive the maximum payment is actually to have their first year in 2012. It's simply a matter of when the program ends. The program ends for Medicare. It ends takes a while for you to get to your maximum payment. Again, all of the payment schedules are listed online, and you'll be able to see kind of how you can fit the adoption and use of EHRs into your practice in order to get as much of the incentive dollars as possible. Here we just see some of the program milestones. We see the point in 2012 where the last day for eligible professionals to register and attest for incentive payments in calendar year 2011. And so that's a matter of the reporting period. So you have to be mindful, again, of that 90 days, and then in your year 2, it's, again, the full year. So at this point, I'd want to make sure to draw your attention to some of the resources that are available to you online. Again, the website that you see here is the main CMS EHR Incentive Programs website. That's where you'll find the calculator. That's where you'll find eligibility information, and FAQs answer a lot of the common issues and concerns that come up. It is good to note, though, that the Office of the National Coordinator has local programs. I can't speak to those specifically, but their website shown at the bottom can help direct you to local resources that can help individual providers choose a vendor, choose a product, and work through the system to get to meaningful use. Excellent. At this time, I'd like to take any questions that you may have, and thank you very much for your attention.
No surprise that we've got some questions for you. So I'm just going to plow in and begin asking the ones that have already been chatted to me. So are you ready?
Absolutely.
All right. First question. As an EP accumulates data for meaningful use, do we count only Medicare beneficiaries or all comers?
As you accumulate data for meaningful use, do you count for only Medicare beneficiaries? So you're saying in your denominator? I'm assuming that that's in your denominator. It would account for all of the patients that you see, but if you're inputting information into your EHR, you will be putting information into your EHR regardless of that patient's payer source. So it won't matter if it's private pay, insurance, Medicare, Medicaid. The thresholds are the program thresholds. I think are what you may be getting to, because for just as an example, you need to have for Medicaid, you need to have a minimum of, I believe, 20% of your population needs to be Medicaid, and so there are certain thresholds under certain circumstances, and for details, I would have to either discuss one-on-one or point you to some of the FAQs online that would apply to your particular practice. But the EHR is going to collect information on every patient, and when you report, it's going to report on every patient. The claims, so your eligibility for the Medicare program is going to take a look at the percentage of Medicare patients that you serve. Same with Medicaid. The other requirements perhaps that involve percentage of Medicare or Medicaid patients that you see may have to do with actually the claims data that you report, and as an extension of that, the amount, your ability to get the incentive payments, because again, your claims have to be, you have to be able to claim $24,000 in that first year in order to get the $18,000 in incentive payments for your first year, and that's based on your Medicare claims.
That's 75%. Yeah.
Right, the 75%.
Yeah. If an EP is using two different EHRs, should they manually aggregate the numerators and denominators for attestation?
If you're using, now that's a tricky question. I don't know. See, this is where it gets down into kind of specifics of the situation. If you're using two complete EHRs simultaneously, first of all, I'm not entirely sure why that would be the case, because if they're both complete and they're both certified, then your data would have to be, they would have to communicate with each other in order to, as you say, aggregate the total patient information, because otherwise you're not going to be able to report. Your numerators and denominators are going to be incomplete. You're going to have numerators and denominators for one EHR that only represent, say, half of your actual patient encounters. And so you will need to have a system that will report on all of your patient encounters and all of your actual meaningful use, numerators, denominators, exclusion criteria, etc. So there will need to be communication between your systems if you're using parallel systems. If I understand the question as running two parallel systems, if the question relates to modules, then the modules should be connected as well. They should be again, interoperable, and the definition of a complete EHR means that the modules are addressing each aspect of meaningful use, they are communicating with each other, and that ultimately they will produce a single report that you will use to attest.
Well, good. That just answered that question from me, Tandy, about modular products. Is the 90 days to capture charges only a minimum time frame? Can I use a longer time frame if my provider does not have the charges?
If your provider does not have, I'm not so sure about the last part of that.
Neither am I, yeah.
But the 90 days applies only to your first year, and it's fixed. And so the 90 days is the 90 days, and you can choose whatever 90 days you want, but you can't report on more or less and meet the meaningful use requirements.
Okay. Is an EP limited to meeting MU by using only the quality measures that a certified EHR vendor has tested for, or can they use ones not listed at the chapel site as being tested by that vendor during certification testing? That's kind of a mouthful.
Okay. The modules that are used must be certified. If it's a little bit, let me answer it this way. If you are using a system and you're using it for 90 days and the system does not functionally, structurally change, but it becomes certified, on day 2 of your use, do you have to throw out day 1 of your numbers because it wasn't certified at that time? The certification, as long as you can report on the data and as long as you can report on your meaningful use, so your system is recording information, it's going to be able to report on that information. The actual the certification of that system is absolutely critical, and every component of your system needs to be certified. So you're going to have to have a certified EHR component or complete system for every measure, so that you have the ability to capture and report on every measure, whether you actually do or not. Having said that, if your certification comes through a little bit later on, you're still able to use that system and record the information you need to record. The certification, the complete certification number, is achieved. You want to go in and you want to get that right before you attest, and that is literally a process of going into the chapel's CHPL system on the ONC website, and it's sort of like a shopping cart. Literally, I mean, you go in and you select, all right, I have this system and this and this and this, and the chapel system takes a look at all that and says, all right, that all adds up to a complete certified EHR, and then it gives you a complete certified EHR number, and that's the certification number that you then put into the attestation system. It's only at that point that you do it, and so as long as you are able to get that complete certification number, plug that into your attestation system and run your report, and that report is accurate, you can attest that it is from a certified system, that will meet the meaningful use requirements.
Would you clarify for a couple of our attendees who've chatted in this difference in Medicaid population from 20% versus 30%?
That is a good question, and I am not going to be able to address that in detail because I don't want to give any partial information. But what I can tell you is that there is a distinction between the type of practice setting, and that a critical access hospital and an eligible hospital and an eligible professional under Medicaid do have slightly different requirements. Although, if the questioner would like, I'd be happy to follow up after the call to go into more detail on that.
Yeah, and there's Ethan's website right there if you want to email him, email him offline. Does certification mean that a system will generate the reports needed for attestation?
I'm sorry, one more time?
Question on certification. Does certification mean that the system, the EHR system, will generate the reports needed for attestation?
Absolutely. It's one of the primary, it's an absolutely essential component of a complete certified EHR, is that it is able to both collect all the information that is required by meaningful use, and then you hit a report button and it reports. And so it literally just lists out all of the numerators, all of the denominators, the check boxes that you'll need, and you just plug it in to the attestation system.
Yeah. One of our high-tech answers experts chimed in on that chat question related to 20%, 30%. It's 20% Medicaid population if you're a pediatrician, and I believe it's 30% if you are not a pediatrician.
And I believe there are also some different requirements for children's hospitals.
Yeah,
right.
And
so,
yeah, we're just talking on the EP level, right?
Right, exactly. So yeah, that's why there are some different requirements for different practice settings.
All right. So this is another question related to EHRs. Some EHRs only have certain quality measures certified. What if you want to choose a different measure by manually gathering the data?
You would not, if in that situation, you would not be using a certified EHR to gather that data, which means that you would not be meaningfully using certified EHR, and you would not then be able to report on meaningful use of a certified EHR. So in that case, you would not be meeting the meaningful use requirements.
And just a reminder that the chapel list, which is in the reference in the slides, that is the place to get all of the 2011, 2012 certified products by the ONC. So
absolutely, and the Office of the National Coordinator also has a list of vendors that will help you if you want to certify your own system. I know a lot of larger health systems and some smaller ones that have chosen to go ahead and get their own system upgraded or certified as a unique EHR.
So this is another question related to, well, actually, it's actually a very good question. So what do you do if doctors who service different locations and who have different EHRs, would you gather all patient info from the different centers to attest, or would you attest for each center on its own?
Okay, now that is a fantastic question.
That's a great question.
And I can tell you that there is guidance that is currently being written to address multiple practice settings and how that should be done. But what I can tell you at this time is that registration and attestation and meaningful use applies to the eligible professional, and so it is centered around that physician meeting the meaningful use requirements. And so as long as that physician is using certified EHR, it will be in the physician's name and not the clinics or wherever they're actually practicing. So there's sometimes a little bit of a confusion, I think, because it's for eligible professionals, it's your name, it's your provider identification, and ultimately it's your bank account that's on record that will receive the incentive payment funds. It's different for a hospital. So with a hospital, you've got a whole lot of physicians usually working to meet, and nurses and practice managers and every other type of provider out there trying to meet meaningful use. In that case, it's the hospital and not the individual professionals who would be receiving the incentive payment.
That really was a great question, and it's good that we've got some clarification coming that way. If the Medicare Advantage EPs do not meet requirements by 2015, are the penalties they're subjected to, are they the same as the fee-for-service EPs program?
If you are an eligible professional, so if you are eligible for the EHR incentive programs, then you are also eligible for the penalties. So it's kind of a funny way of looking at it. But if you are able to participate in the program and receive the incentive dollars, then you're also able to receive the reduction in reimbursement. The first year, I believe, is 1%, going up to 5%. So in Medicare, there is no reduction in Medicaid claims or reimbursement.
Right, right. Another good question. Well, they're all good questions, but if the EP works in a hospital setting and a practice setting, how does this work?
Oh, that is a great question. There's a 90% threshold, and essentially what that means is that if an eligible professional is working in a hospital and in a private practice, for example, their billable claims, and this is based on the place of service code. If their POS code is 21 or 23, and if that code is reflected in their claims to the tune of 90% or more, then they are listed, they are considered as a hospital-based provider. And in that case, they are not eligible for to be an eligible professional. They are considered, not a hospitalist per se, but they're considered a hospital-based physician, and they would be then contributing to that hospital's ability to meet meaningful use, and they would not be able to get incentive payments themselves. And on a personal note, I can tell you that I've spoken with a lot of physicians who have struggled with this particular one, because there are a lot of physicians out there who are who are in private practice or at a clinic, but they're also kind of moonlighting in an ER. And that happens all the time. It's really important to remember that 90% threshold. If you don't meet that 90% threshold this year, and you would find that out through your registration. So when you register to be an eligible professional, that's when we go back, CMS goes back, and we check your claims. And that's for the most recent claims data year that we have, which is likely to be the year prior, of course. And so we go back and we check that. And, sometimes it happens where everything else is perfectly fine, but if you just don't hit that 90% threshold, you won't be eligible.
Okay, great. Ethan, we're wrapping up our hour. Thank you so much for your time. We're obviously going to have you come back to HITECH Answers at some point and do another event for us. For those of you who attended, we will actually post all the questions, the ones we got to, and actually the ones we didn't as well, in the FAQ section of HITECH Answers, and we appreciate your time today. If you have any questions for Ethan, reach out to him directly, or you can also, of course, ask us through HITECH Answers. Shoot us an email at info@hitechanswers.net.